Good morning, good afternoon, good evening to everyone around the world. And thank you so much to join the ACNS ISMINS webinars. Today we will have a very exciting webinars about the bypass surgery. We have two speakers of today. The first speaker is Professor Lucia, who is the neurosurgeon and the former director of the section of neurotraumatology and vice chief of the neurosurgical department of neurosurgery of City Hospital in Italy. Her topic is extra-intracranial bypasses from the origin up to date. Lessons learned after more than 50 years of experience. Our second speaker is Professor Hirofumi Nakatomi, who is the professor and senior consultant neurosurgeon of the Division of Surgery, the University of Tokyo in Tokyo, Japan. He will be talking about pathophysiology and treatment of giant, large, fusiform and dolichoectatic aneurysms with special reference to vertebropapillar junction and basilar artery trunk. We have two chairs of today. The chair of the first session of today is Professor Naoki Otani, who is a clinical professor of the Division of Neurological Surgery, Department of Surgery of Nihon University School of Medicine, and the vice president and the chief manager and center of the brain tumor and skull-based lesions in Nihon University Hospital in Tokyo, Japan. He will also give a one-point lessons after the two speakers on basic surgical tips on EC-IC bypasses. Our second chair of the second webinar of today is Professor Naoki Otani. Professor Ota is the vice director of Sapporo Telsinkai Hospital of the Stroke Center and the Department of Neurosurgery in Hokkaido in Japan. He will also share a one-point lessons after Professor Otani's one-point lessons on protective bypass strategy. For the discussion of today, we have Professor Wada, who is the professor of the Department of Neurosurgery of National Defense Medical College, Namiki and Tsugawa in Saitama, Japan. And second discussion is Professor Yasushi Shin, who is a medical director of the Department of Neurosurgery of National Hospital Organization in Osaka, Minami Medical Center in Osaka, Japan. To moderate the session with me, we have Dr. Hui Fem and Dr. Biswa and Dr. Atik and Dr. Liu with me. So without further delay, shall I invite our first chair, Professor Otani, to chair Professor Lucia presentation.
I try to reproduce.
Please try to share.
Could you see? Is okay?
Please try to share it now.
Yes, share. I already, we had a lot of problem with this. Let me do it again. Condividi schermo intero and
Professor Otani, is that you can share the.
Is okay?
Yeah. Thank you. Thank you, Dr. Ren. Yes, yes. I can see your slide. Hi, Professor Lucia, please.
Yes, is okay
yes,
now?
Yes, yes.
Could you see?
Yes, yes.
Okay.
Yes.
Okay. Mr. Chairman, dear colleague, Yoko, and all attendees people, good afternoon. For you, it's 7 in the p.m. Today, I'd like to take you through the origin and the evolution of the extra-intracranial arterial bypass over the last 50 years. The goals of my presentation are really simple: to retrace the history of the bypass from its very beginning, to show the current state of art, and to highlight the main lessons we have learned along the way. The timeline is in this slide. As everybody knows, the first bypass was performed by Donaghy and Yasagil, one in Zurich and the other in Vermont in 1967. After this, most of the population of neurosurgeons fascinated by this new technique and by the many perspectives it seems to open, start to perform bypasses. And in 1973, they met together in the first symposium on extra-intracranial bypass that was organized in Loma Linda, California. And in this symposium, participants decided to meet starting from 1 year later to organize a symposium every 2 years in order to share experience and to evaluate the result. And from 1974 to 1984 was organized symposia. I show you later the list. But it seems to can continue like this. But in 1986, the results of the Canadian study, the cooperative study, were published. Here you have the list of places where organized the symposium in Asia, in the United States, and in Europe. But because of the increasing frequency with which the procedure was performed, the National Institute of Neurological Disease and Stroke became interested in performing a randomized trial to test the value of the procedure. And the purpose of the study was to determine if extra-intracranial arterial bypass was better than aspirin therapy in reducing the risk of stroke or stroke-related death. And the study enrolled 1,400 patients of specific population from 71 centers around the world. And the study conclusions were really discouraging because bypass surgery seems no more effective than aspirin therapy. The study has some bias and some receive a lot of criticism. The first one is that the financial support to the study was offered by Bayer company, the company producer aspirin. And the other is no good selection of patients because in this they speak only of ischemic disturbances. Doesn't matter if for hypoperfusion or for embolic or hemodynamic reasons. Despite all this criticism, the number of procedures performed annually at the beginning dropped dramatically worldwide. But the history couldn't stop. When the result of the cooperative study appeared, another symposium had already been planned in Florence in 1986, and I was one of the organizers, and you can imagine my disappointing. Still, we decided to go ahead, just changing the name, the title, and the logo of this symposium that became controversies in extra-intracranial arterial bypass for cerebral ischemia. And we, instead of the line indicating the bypass, we put a question mark. And this is the book who went out, was published after the symposium. You see on the left, you have the cover we have in mind. On the right, you have the cover we had to do, we had compelled to do. At the end of this symposium, Dr. Awad said, don't throw the baby out with the bathwater. We must take something good from all our experience. And all participants agree on few important conclusions. The necessity to identify really hemodynamic patients, the only ones who can truly benefit from the procedure, to continue to collect and share results and publish results and improve selection and technique, to consider the procedure still valid option for patients other than ischemic. For instance, patients where a sacrifice of a major vessel is required. And last but not less important, to continue investing in training courses. And now we go, after pass through the storm, now we continue our history. At present, recent literature confirms that cerebral bypass is still living, and but indications have been refined, as well as technique, selection, imaging, and perioperative management. For speak about the current state of art, I analyze in the recent literature some selected studies. This is the result of an electronic survey distributed to a total of 51 neurosurgeons in the United States, where there is a confirm that cerebrovascular bypass surgery remains widely practiced, but technique, perioperative management, imaging technique has been refined, and the important to guarantee to the patients the best outcome and to continue to cooperate and share technique and result. And the other paper is the result of a systematic review of 50 articles about cerebral revascularization that show that revascularization for steno-occlusive disease improved over time when compared to the first period it was performed, only because of the improvement I already told you. This is a confirm of the previous one. Another two very important articles, in my opinion, are this one from University of Zurich, and the other that is the experience of only one surgeon, Professor Lawton. In this paper, the University of Zurich report the current evidence, state of evidence, and grade of recommendation for bypass. And they say that it's true that the Canadian study narrowed the indication for bypass. However, it's still very useful, the extra-intracranial bypass, for managing complex aneurysm not amenable to direct clipping, and it's remain the only one treatment option for managing symptomatic patients with moya-moya vasculopathy and selected impaired brain hemodynamics patients. The other is the results of a 21 years experience of Professor Lawton that performed bypass mostly in cerebral aneurysm, because he is the director of the cerebrovascular structure. And the second place, the frequency of bypass performed is for moya-moya disease, and the third place, intracranial arterial stenosis occlusion with hemodynamic impairment. And they concluded that intracranial bypass remains essential technique that must be in the armamentarium of any open vascular neurosurgeon. In my experience, we don't know Moya disease more or less in Europe, and our series here represented only by 65% by hemodynamic patients, and the remaining are more or less tumor, and at the beginning of our experience, and aneurysm. With with good results and no failure of the procedure. This is no for you. I didn't know at the beginning if some participants could be from Europe, so I put this slide to remember them that is a rare cerebrovascular condition that has the highest prevalence in East Asia. And for this, I selected papers from Asian literature. And the first one is from the school of Professor Bing Shu that conclude that superficial temporal artery to middle cerebral artery bypass combined with encephaloduromyosynangiosis used for treating Moya disease showed a good therapeutic effect in these patients. And the other is the evaluation of outcome in adult patients with hemorrhagic Moya disease. And in these two, the revascularization provide a benefit over conservative therapy with improvement of dilatation of branches, and that may be correlated with a low rebleeding rate. And the third one I select is the evaluation of the bypass on cerebral hemodynamics study in a population of adult Moya, where they show an improvement of preoperative hemodynamic. I told at the beginning something about the training, and for this we need another webinar, I think. But just a few words, because this is a very important point, because to guarantee our patients with the best possible treatment, we need to produce surgeons well trained. And there are several models to organize training courses. In my opinion, one is it possible. The best one is a living model because the surgeon empathy with every being living cannot be underestimated. Going again, our conclusion, we learned that the rationale for performing bypass is double, or to restore blood flow in an hypoperfused area, that is a flow augmentation, or to replace blood flow in a brain territory previously perfused when we have a need to sacrifice an artery. And this is the bypass for flow preservation. Flow augmentation is the bypass that we perform in an hypoperfused area, and is the case of patients with Moya disease or selected symptomatic cerebrovascular patients with hemodynamic impairment. And the flow preservation is the case of patients with aneurysm not amenable to direct surgical clipping or tumor when you need to sacrifice a vessel. Both these cases decrease in time, especially for improvement of the alternative technique. First of all, the endovascular improvement. In conclusion, The extra-intracranial bypass, I consider it an important training ground for us neurosurgeons in 70, but it remains a cornerstone in vascular neurosurgery. But the procedure can remain a low-risk procedure only in experienced and well-trained hands. Let me give you just two take-home messages, and after we can open to the discussion. The cerebral bypass remains an important treatment option for selected cerebrovascular condition, moya or impaired hemodynamic, and continuous training, cooperation, sharing technique results are essential key to improve surgical quality and, most important, patient's outcome. Thank you very much for your attention.
Thank you so much, Professor Lucia, for your talk. Your talk is so interesting and inspiring talks for us. So
thank you.
You showing the the history and the trend of the ECIC bypass in the worldwide, yes. And in your slide, so in 1967, so Yasuju has firstly experienced the ECIC bypass in 1967. It's my birth year. It's my birth year. Yes, it's very feel deeply emotional feeling.
Really. So, and you must consider that in the same period, neurosurgeons can appreciate the origin of surgical microscope. And this is the one couple of effect. Was the same years.
So, and any question and comment? Professor Shin, do you have any comment?
Yeah? Thank you very much. Very interesting presentation. Very insightful. Thank you very much. I'm very interested in the bypass surgery. And but actually, in Japan, bypass case is very decreasing. But some young neurosurgeons in Japan want to train bypass surgery. How about in European young surgeons? So 10 years ago, I had good time in Berlin with Professor Peter Baikoji Charité. So he loves bypass surgery. So in Japan, so bypass case is decreasing. How about in the European young neurosurgeons?
Yes, in Europe too, the bypass cases decrease. That is true, and for this I stressed the importance of training, because if one case of bypass appears in your patients, you must have the possibility to perform it better. You know that sometimes people call me about putting some question about bypass, because they are not the habit to perform a bypass, and about technique, about small tricks that we have. We must, this is important, and they can be known only if you have a good training. The problem in Italy is another one, that till now we didn't have a possibility to perform training on living models. Just a few years ago, they started to allow these living models because there is a society that protects animals.
Yes, I know. Oh, thank you.
Okay, thank you. So in Japan, I also agree with your opinion that so bypass technique will be essential and fundamental techniques for vascular neurosurgeons. And in my experience, I usually use rat model for bypass training, as you introduced. But now in Japan, so many neurosurgeons will use dry model and on the desks. Yes. And how about in Europe, neurosurgeons, young neurosurgeons in Italy and in Europe?
Yes, there are several courses with different grade, and they improve. They start from rubber with the hands, and after with other models till to the living models. The living animals are better because surgeon need to have something living in the hand. This is the reason.
So another question.
Of course, in a large course, if you have a large course, you can go to other models that reproduce the living as best. There are several. There is placenta or other.
Professor, so Kojiro Wada, do you have any question?
Thank you very much. Very impressive talk you did. And yeah, I agree about bypass surgery is very fundamental for the vascular neurosurgeon. And the entry of the procedure is a bypass. And more and more now we have difficult cases. So such as moya is not good for the entry neurosurgeon. Also the complicated aneurysm, it is necessary the bypass surgery also, but sometimes a very difficult case, and also the ruptured case is difficult. So how we train the young neurosurgeon? I sometimes have a difficult. So how do you think about grow up the young neurosurgeon for this type of the patient treatment?
It's really difficult to organize something. There are some institutions where this is very cared. For instance, last year I went to Phoenix, close to Professor Lawton and Spetzler, and they have a laboratory with animals and large animals, and they have the permission to do every kind of experience training, and in these cases is easy. For us, with less financial support, is sometimes really difficult. But we must find something in order to allow our residents to obtain the best performance. But the same at what happened after the development of endovascular surgery, it appears the same problem with the neurosurgeons that don't have the habit to clip an aneurysm. But when the aneurysm treated endovascularly and kind of material didn't went well, you need to open to modify or to perfect the situation, and if one has not enough experience, this can be a tragedy.
Yeah,
So
that's true. Yes.
we must continue to do this, and it's very important to establish some libraries, because my former chief said surgery can be learned with eyes. So if we organize a library with operation since the beginning to the end, and everyone can look, we can find from this different information and grow the instruction. And when I start neurosurgery, surgical microscope was not there. We obtained the surgical microscope after 3 years. I was already working, and after all developed later. So young neurosurgeons now have much more possibilities, but we must give them all our knowledge or our experience or our thing, because we don't have more experience. We know what can be difficult, and this is important. We must guide them on the way.
Thank you.
Thank you for the question.
Okay. Other question? So from the chat, on the chat, Dr. Harshad Parekh in. So question is in children, moya disease other than revascularization helps same as bypass. What is ESS? So would you please direct question, Dr. Harshad? Can you?
I think you mean the direct or indirect bypass.
Yeah, direct and indirect. If possible, please direct question. Dr. Ben? No?
Yes, Dr. Okay, you can speak your question.
Hello, Professor.
Yeah. Yes.
Yeah. Excellent
yes,
talk. Very interesting and very informative. I'm Dr. Harshad Parekh from Mumbai, India. I just wanted to understand what is your experience in children moya disease for between the indirect revascularization and the ECIC bypass. Many centers are now doing mostly indirect revascularization in children for moya, and rather than going for an ECIC bypass in children especially. What is your experience?
I already told you that in my region we don't have at all moya. Children with moya is another chapter that to be discussed, but I think that in this panel there are other components that can have experience in moya disease in general, and in moya in children particularly. I think we did one bypass, but for reason other than ischemia, we did one or two, a couple of bypasses in young people with aneurysm not amenable to direct clipping, but no moya. I don't have any experience.
Okay, thank you.
Dr. Sheen or Dr. Bada Sensei can reply for his question.
Okay. Salam. Kumbawa. Yeah,
Hi,
thank you.
Hello.
Hello. I'm from Afghanistan. Thank you for excellent presentation and enjoying the webinar. Thank you very much. Arigato gozaimasu.
Shin Sensei, can you reply
Thank
to
you.
Dr. Halsher the question?
Yes.
For children, moya. Maybe we can do
Children,
both.
moya.
Yes.
Yeah. So, for children, moya, do you choose the direct bypass at first, or the indirect? In children case, do you use a direct bypass at first? Or
No, I never
indirect?
saw a patient with moya. I don't know. I don't have patients, children
case.
or
Thank
patients
you.
with moya. Not at all.
So in Japan, the usually we do the both direct and the indirect bypass. So usually the STA, two STA we have. So the one STA, superficial temporal artery, is a direct bypass, and the other one is using for the EDS. Also use the pericranial flap or temporal fascia or temporal muscle for indirect bypass. Also, the frontal area, there is no good vascularization. For this purpose, pericranial flap, craniotomy and pericranial flap connect to the frontal dura. So that effect good deep vascularization for the children, I believe. Thank you.
So that is in one stage, yes?
Yes, one stage, one side. So 1 to 3 months later, we do the other side also, usually.
Any question? Another question? No? So I agree with Professor Kojiro Wada. I also use single direct bypass and with indirect. So in children cases, infant cases is very, very effective. Just only the indirect bypass. But how do you think about the age? So not effective of the indirect bypass. So so for the aged patient, do you use indirect bypass for the not infant cases? Do you use the indirect bypass, Dr. Kojiro Wada?
Thank you. Yes, that's a big good question. I wonder the indirect bypass effect or not. I don't know, but some people said indirect bypass is very effective for about 60%, but in my case, 30%.
I see.
Effect
Thank you.
for the adult case.
Thank you so much. So the time has came up. Any other question, comment? Okay, Professor Lucia, thank you for your excellent presentation, and I can learn the history of the bypass ECS bypass period. Yes.
Thank you for all of your comments, and I already sent my presentation by mail to the organizer. So if someone wants to use it, you can do it.
Yeah. Thank you so much.
My presentation is available for all of you or all who are requesting it.
Thank you very much.
Thank you so much.
Thank you, Otani, chair the first session. It was a wonderful session. So we proceed to the second session with the chair, Professor Ota, to chair Professor Hirofumi's lectures.
Yes, hello, I'm Nakata. I'm chair this next session, and it is a great honor to introduce our next speaker, Professor Nakatomi. He's not only one of the most outstanding cerebrovascular surgeons, but has also made major academic contributions through his important work on fusiform or vertebral artery, basilar artery dolichoectatic aneurysms, and other complex aneurysms. So today, his topic is pathophysiology and treatment of giant or large fusiform and dolichoectatic aneurysms with special references to vertebral valvular junction and vertebral artery trunk. Professor Nakatomi, please start your presentation.
Okay, can you see my screen? I'm sharing my PC laptop.
Yes, we can see.
Please. Yes.
Okay. My name is Hiro Nakatomi from Tokyo, Japan, and it's a great honor to share my study with all of you. And actually, Professor Ota is my all the collaborators for this study too. And I really appreciate Professor Kato for giving me this opportunity to share this study. Today I'm going to talk about pathology of these giant large fusiform aneurysm and also potential drug treatment. And the ultimate question for all the vascular surgeons should be, if you are treating the fusiform dolichoectatic aneurysm, particularly at the basilar trunk or VV junction, what is the clinical pathological features? Then how we can visualize any high-risk perforators around these aneurysms, or how can we decide which treatment should be best for this particular grave disease, and ultimately, is there any chance of drug treatment? That's our talk today. Then initially, we collected many sized fusiform aneurysm from the small to the biggest. If we look at these less than 10 millimeter fusiform aneurysm, the arterial structure started to have the fragmentation of internal elastic layer like this, and the thinning of medial layers, accompanied by the intimal hyperplasia. Then if the fusiform aneurysm gets to more than 10 millimeter, the internal elastic layer has been shrinked and almost gone, and the intimal hyperplasia gets to be severe, and recanalized vessel formation in this intimal hyperplasia was found. So this recanalized vessel formation is the key event to have the vessel wall enhancement. Then if the aneurysm gets to more than 20, we don't see any normal medial layers or adventitious layers. Almost all the component of arterial walls is fragile intimal hyperplasia and thrombus and dissection. Then you can see in most cases, all of these fusiform aneurysm has the basal formation around the aneurysm wall at the adventitial layers, which means outside of the vessel. Then ultimately, I got the specimen with the brainstem. Then if you look at this, the most compressed region, we initially thought the perforating vessel within the brainstem, compressed brainstem, has been already occluded, but it is not, which means whenever you intend to induce the thrombosis of aneurysm, you can have the higher risk of occluding the perforating vessel within the brainstem altogether. So that is my most important findings. Then we only talk about the most formidable grave basilar trunk and the BV junction giant large fusiform aneurysm today. If you treat these patients conservatively, most of the patients will die within the 5.5 years. So you should do something, some treatment. Historically, we did the immediate proximal occlusion very close to the aneurysm neck so that we can optimize complete thrombosis, but minimize the collaterals, even in the brainstem. Only younger patients, like a 20s or 30s patient, has tolerated this procedure and remained the same neurological status. So let me just show one case. We got this 17-year-old lady, actually girl, high school girl, presented with cerebral arachnoid hemorrhage from this giant basilar trunk aneurysm. Then we analyzed these 3D computer graphic analysis. This looks like her aneurysm left side has bled. Then looks like her left side aneurysm wall has the highest wall shear stress. Then this is the point, the aneurysm ruptured. Then we did angiogram and balloon occlusion test at the basilar artery. And apparently she could tolerate even with the collateral circulation development with as well as the stamp pressure while occluding the basilar artery. So we thought we might be able to occlude the basilar trunk for this ruptured basilar trunk aneurysm. Then we simulated through the 3D computer graphics. We thought this aneurysm neck has bilateral ICA origins. And initially we thought if the aneurysm incorporated this ICA branching point, we might need to bilateral OA ICA bypass. But initially I prepared. But I consulted to Dr. Tanikawa and Kamiyama and Ota and all the members in Japan. And everybody said, if we occlude the basilar trunk beyond the ICA segment, that's okay. But if you occlude the basilar trunk pre-ICA segment, you will have the highest risk of inducing the thrombosis of basilar trunk and leading to the brainstem infarction. The conclusion from all over Japan's expert is occlude the basilar trunk at the post-ICA segment. Then also we simulated whether it's possible through these 3D computer graphics. Looks like it might be, but we are not certain. So we did every effort to prepare for this grave disease. We plan to prepare the OA pica and the SCA, and through the left side, transcondylar plus presigmoid posterior petrosal approach. If it bled again, we will decide to trap this aneurysm at post-ICA segment as well as the pre-SCA segment. Then we did the surgery, preparing the OA and the STA from this young girl, and prepare the OA from the neck side, and prepare the STA from the front side, and did a complete transmastoid retrolabyrinthine approach together with the transcondylar approach. You can easily see the VA and the basilar segment. And since the aneurysm is sitting low enough, we can look at the back side of basilar trunk. Then you are looking at the left side ICA as well as right side ICA at one view. Actually, you are looking at the back side of basilar trunk. So you can easily confirm now if you can clip the post-ICA segment, you don't have any perforators below the ICA. So we initially put the temporary clip pre-ICA segment, then created the post-ICA segment enough room. And since it's tough to control the aneurysm pressure, we did the adenosine cardiac arrest with collaborating the anesthetic surgeon. And during the cardiac arrest, we can put the fenestrated clip to the basilar trunk, and we can secure the bilateral ICA segment enoughly. Then we confirmed the intraoperative angiogram and ICG, and finished the case. Then post-operative angio confirmed the bilateral ICA preservation, and she didn't have any diffusion ischemia at the basilar area. And actually the aneurysm thrombosed over 1 year, and she returned to the previous high school, and she's now a nurse to taking care of the neurological patients. So this is actually the most successful case. After 2 years, aneurysm shrinkage. But how about the older case, older patients? Since the older patient wouldn't tolerate the basilar trunk or proximal clipping, we prefer to use the remote proximal occlusion. I think this is the only way to save this patient, this type of patient. Let me show one case. This gray basilar trunk case came with the brainstem compression, and we did the similar simulation. Actually, this gentleman had the big PCOM on the right side, and his anterior spinal artery is exiting from the right side vertebral artery distal point. And the key for this case is this pica. This right side pica is very close to the aneurysm neck, so that we might be able to maintain the outflow through the PCOM. So we plan to, and we did several computational fluid dynamics, which procedure will create the lowest wall shear stress at the basilar trunk, but I skipped today. And we did the bilateral vertebral occlusion test. He tolerated, and stump pressure is good. Then we decided to do this. At first, we occlude the left side vert here, close to the aneurysm. Then through the PCOM, there should have some basilar trunk inflow from the PCOM. Then we will do the next contralateral vertebral occlusion through the endovascular technology. Then actually this procedure, this strategy is creating the new inflow and outflow through the basilar trunk to the small pica. So this case attained the most beautiful, successful result. After 4 years, this aneurysm gets to 1 centimeter, and he started to walk with his wonderful dog. And I think creating the new inflow and outflow through the basilar trunk will be the key issue for this grave basilar trunk aneurysm. Also, this case is quite similar. This bilateral VV junction aneurysm, he didn't have any PCOM. Then we plan to create the vertebral artery V3 to P2 segment bypass with radial artery graft through the right side posterior petrosal approach. And we did. Actually, this case was done 1997. And he is now still active after 26 years ago. Then we did this P2 bypass through the posterior petrosal approach, and he tolerated very well. And again, this case also had the pica on the left side. Then ultimately, we can create the new inflow through the P2, the new outflow to the contralateral vert to pica. So this case didn't have any problem. Then again, similar case, this young gentleman came with similar symptoms, but unfortunately, this gentleman had the contralateral outflow pica is remote from aneurysm neck. So we had some worry. This patient might not be able to achieve the inflow and outflow tract new creation. But since we didn't notice the importance of new inflow and outflow creation strategy, we did balloon occlusion test, and he didn't tolerate it well. So we did the right side V3 to P2 bypass creation by hoping to supply the new inflow will supply to the old original pica outflow. Then this is an operation similar to the first case, doing the posterior petrosal approach. We are now demonstrating the cosmetic mastoidectomy and complete foramen magnum opening and the transcondylar approach so that you can see very well. And by completing the transpetrosal approach, we are now looking at the P2 segment. And this gentleman had some posterior lateral posterior choroidal artery there. So we did similar temporary occlusion with AVM creep. Then to the P2 segment bypass, since it's deep and a small space, we often use ventricular drainage to create the wider space to do the enough freedom, to get the enough freedom. Then creating the very careful suture, stay suture with weakly bended and insulated these 20 centimeter forceps. These gold-coated forceps is very nice to do this deep and narrow bypasses. Then after completing these important stay sutures, we can carefully do the interrupting sutures one by one with the two-thread technique. I can skip the rest. Then by completing the aneurysm, P2 bypass, then anastomoting the cardiac end to the proximal vert and confirm the intraoperative angiogram. Then he didn't have any trouble with the procedure and creating the new inflow P2 through the basilar, but the bypass flow couldn't reach to the contralateral outflow pica in this particular case. We induced the complete thrombosis of basilar trunk aneurysm. Then he couldn't he couldn't get the improvement neurologically. He stayed a severely disabled situation. So these are the summary for recent cases. only a young patient with the enough collateral within the brainstem, and other case with new inflow and outflow creation technology strategy attained the better results. Then this is a summary. Younger patient could tolerate the surgical procedure well, but for the older, more than 45 years old cases, you need very careful to maintain the vaginal trunk for this grave disease. Then what else we can do? We collaborated all over Japan to create the new strategy for this grave disease. Actually, we collaborating more than 7 years. Dr. Otter and Dr. Tanikawa and Dr. Kamiyama, all the years to get the sample of aneurysm specimen. Whenever Dr. Otter did the surgery, he collected the aneurysm specimen and he sent all the specimen to me. And my lab in the Riken analyzed the somatic mutation for all the aneurysms. Surprisingly, these fusiform aneurysms had the cancer gene, kidney cancer gene in the vessel wall, which means if we have the medicine for cancer, kidney cancer, this drug might be possibly redirectioned to the fusiform, intracranial fusiform aneurysms. Then these fusiform aneurysm specimen we analyzed. The key molecule is PDGFR beta, which is a cancer gene. This molecular cell has proliferated in the aneurysm wall, and it destroys the aneurysm smooth muscle cell. Then eventually the arterial wall strength has been lost. Then this vessel wall has been expanded to the fusiform-like shape. Then we did the animal model, which reproduces this hypothesis, and this kidney cancer medicine has suppressed the fusiform aneurysm formation. We are now preparing for the clinical trial for this kidney medicine to be used for the fusiform aneurysm treatment, either adjunct or the primary or secondary treatment. Then this is a summary for the fusiform aneurysm hypothesis. Most of the fusiform aneurysm carries the PDGFR beta cancer gene mutations, so that we can apply the new tyrosine kinase kidney cancer medicine for this grave disease. Thank you very much for your attention.
Professor Nakatomi, thank you very much for your excellent presentation. His presentation shows a great outcome of surgical treatment of the vertebral vaginal artery, and also shows a limitation of its surgical treatment. And there is a future perspective for drug usage for those fusiform or giant aneurysms. Are there questions or comment in the audience? So can I have a discussion, Professor Wada?
Thank you very much, Professor Nakatomi. It's a very complicated aneurysm and difficult case. My question is, every time you perform this type of flow alteration therapy, I think you use flow dynamics, you check every time. So because the facility is limited for using the flow
dynamics studies.
Dynamics. So if the dynamics is necessity, it limit to do the such a difficult case. So I wonder the flow dynamics is needed or not. So
thank you very much, Professor Wada. The necessity of computational fluid dynamics is questionable, but it's desirable. But I would say, since this, I talked with all over the world experts, including Professor Lawton and Peter Bezgocki and other Switzerland and all the experts has the experience with this grave disease. Still, they have the similar, not satisfied result, like a success rate is around 50 or less. I think by accumulating the complicated failures or actually complications with this grave disease, we can figure out what is better, and what is best. The use of computational fluid dynamics is one example to understand which surgical action is better. And to introducing the computational fluid dynamics, we tried the branch artery occlusion technique, which has been advocated by Professor Miyamoto from Kyoto University before. And we applied his strategy with collaborating computational fluid dynamics. But unless we reduce the main inflow pressure, we couldn't stabilize the aneurysm wall anymore, even with the branch artery occlusion technique. So since then, we stopped the branch artery occlusion technique. We are now leaning towards creating the new inflow and outflow tract to achieve the less than actually 10%, 90% reduction of the basilar trunk wall shear stress. I think that is the most promising strategy. But anyway, since this surgical procedure itself is very complicated and not all the institution can do. So we think we need next step so that we study to analyze the aneurysm wall collected from all over Japan and even from the United States or Europe. We are very welcome to collaborate. And since we have a strong collaboration with Riken, Japanese Research Institute Riken, and they are very welcome to support this study to initiate the aneurysm drug creation in the world. So we are very welcome to collaborate even with Asian and Australian countries.
And can I have another question?
Yes.
So you use the high flow bypass, so we do the VA, and in case of the PCOM, in case PCOM is a good patency, you didn't enough high flow bypass. I mean low flow bypass is enough for these cases. How do you decide a high flow or low flow or no reconstruction surgery? That depends on only the flow or dynamics.
Thank you very much. Great questions. We always perform the basilar trunk or bilateral vertebral artery occlusion test with MEP or SEP or neurological status. If the patient showed any decline of consciousness, we will choose the high flow bypass. If the patient didn't show any symptoms, but the stump pressure showed some decline, some decrease, we prepare some low flow bypass. If the stump pressure remained more than 80%, we won't use bypasses. We are totally relying on this balloon occlusion test with the stump pressure and many neurophysiological monitorings, MEP or SEP, and so forth.
Thank you very much. And one more question
Yes.
I have. So after preoperative and postoperative, do you use antiplatelet therapy also?
Actually, yes. We use bioaspirin for all the case preoperatively. And particularly during and immediately post-operation, we use anticoagulation too, at least 1 week. Then depending on, so actually we need to induce the very slow thrombosis for this brainstem aneurysm, and so that we can maintain some collateral flow development within the brainstem. That is the only way to achieve or avoid brainstem infarction for the aged more than 45 years old group.
Thank you.
Thank you. Can we have another comment from Professor Shin?
Yes. Thank you very much, Professor Nakatomi. Very insightful lecture. Thank you very much. So what is the proposed mechanism for underlying brainstem edema? Do we have some idea?
Let's say, yes, of course. Since the blood-brain barrier has been created by the tight junction between endothelial cell plus plus astrocyte, then these aneurysm has been infiltrating these adventitial vessel wall already. So the brainstem blood-brain barrier with the brainstem parenchyma has been already destroyed.
Thank you very much.
Yes.
Thank you. And we have a question from Dr. Ben.
Yes. And thank you so much, Professor Nakatomi and Professor Ota, for this great study and great presentation. And some of the questions already mentioned by Professor Wada, and I'm very happy to know about the role of the balloon occlusion test. And I want to ask about in the balloon occlusion test, besides the clinical parameter, do you also monitor the MEP and SSEP with the intraoperative monitoring?
Yes, if it's possible, you should.
Oh, okay. And my second question is about, I saw that some surgeons will do the bypass and the trapping in 2 different stages. They may perform the bypass first and then to perform the trapping later. And some will choose maybe the ICA radial artery graft to the P2 bypass. So any comment on that?
Yes. By using the donor as by using the vertebral artery as a donor, we have intermediate high flow bypass, and the flow rate will be less than ICRA to P2 bypass, so which has the higher chance of inducing the thrombosis aneurysm wall, not the real indeed flow, but induce the thrombosis within the aneurysm wall. The too much flow through the aneurysm will not induce the thrombosis, so we need to be careful which donor should be chosen for this very tough situation. In my series, internal carotid artery might be too much or too good to perfuse the entire aneurysm wall. We are hoping gradually less and less flow into the basilar trunk. So I think we have better chance to achieve the slow thrombosis by using the vertebral artery as a donor.
So any comment on whether you should do it 1 stage or 2 stage?
Okay. It depends how, I would say, whenever you occlude the one vertebral artery or 2 vertebral artery at one time, you will have higher chance of the brainstem ischemia. I would prefer to stage surgery, creating the bypass first. Then after stabilizing the neurological condition, we might do the second stage basilar trunk occlusion or contralateral vertebral artery occlusion. We need to be certain he or she is okay through the first surgery, or then we can decide to proceed with the second surgery in 3 months or 4 months.
I see. Really great. And my last short question is about, so I'm very interested in those your findings for the palate-derived growth factor beta. So
yes.
Is this trial undergoing in Japan? So if you have let's say we have some patients that we cannot manage and by surgery, so can we refer it to your trial?
Actually, yes. Actually, we are now accepting Chinese and Indonesian cases. So we are very welcome to send any patients or any samples to us. Because we are already Asian Australian team to fight with grave disease. So we are very welcome.
I see. Thank you. Thank you so much.
Are there any comments?
So can I question one question? Dr. Nakatomi, thank you. So you are excellent cases and most surprising. So my question is about for thrombosed giant aneurysms with basurums. So it has been usually said, so just only proximal occlusion and flow alteration with bypass reconstruction. It will be impossible to enlarge the thrombosed with basurum cases. So it usually it will be necessary to complete trapping will be needed to manage the thrombosed giants with basurum cases. Do you have any comment and opinion for
very
this?
much. Yeah, very important questions. Please look at this one. This basilar trunk aneurysm has a huge inflow side and outflow side. And if you trap this aneurysm here and here, you will induce entire brainstem infarction. So I wouldn't recommend, particularly for the older age patients, you will 100% suffer brainstem infarction. You can only try the remote proximal occlusion at the C12 segment on vertebral artery both sides for the older patients. And these aneurysms always carry a profound number of the basurum, which means even you are attacking through the endovascularly, it's not enough because even with the inside occlusion, you cannot manage anything at the outside. Basurum will supply additional nutrition to this tumor-like aneurysm wall. So I think we surgical arm still have the important role to eliminate the basurum from the extravascular space. So it's very important notion and aspect to know.
So does do the gamma knife will be effective or not?
Actually, Dr. Kano from the Tokyo University asked me, actually, if the gamma knife can eliminate these recanalized vessel in the aneurysm wall, as well as occlude these vasovasorum by radiation, they might have better chance.
Thank you so much.
Yes.
Thank you for your opinion.
Thank you.
Thank you, Professor Nakatomi, for great presentation and discussions. So time is limited. We go next.
Okay. Thank you.
Thank you very much.
Sure.
Okay, so maybe we shall proceed with our one-point lessons. Maybe we first have Professor Otani to talk about the one-point lessons.
Just a moment. I will share my slide. Okay, can you see my slide?
Please change to the presentation mode.
Just a moment, please. Okay. Can you hear? Can you see my slide?
We want your screen with not in the presentation mode.
You must share the entire screen.
Just a moment. Entire. Okay.
Entire screen.
Hey, Dr. Ben, can you see my slide? Entire? No?
No. Small.
No. Just a moment, please.
Try to unshare and share it again.
Can you share my slide? No?
Yet now it's not shared.
Not share. Oh,
It's sharing now. Oh, yes, it's okay.
Yeah. Sorry. I'm so sorry. So thank you for just a moment. Okay, thank you for my opportunity to present my my works. So today, my talk on the focus on the basic surgical tips on EC-IC bypass, in particular the STMCA, basically bypass. So for young neurosurgeon. No. Oh, good. Okay, move my slide. Dr. Ben, move my slide.
Yes.
Yeah, sorry. So today's my agenda is for these contents. So at first, I will show the indication, surgical indication for in Japan. So asymptomatic cases, we usually observe under medication with antiplatelets, single SAPT method. And for asymptomatic TIA or the minor strokes, we usually perform the quantitative SPECT like this. And normal CBF is less than 80%, and diamox reactivity is 10%, less than 10%, which shows a vascular reserve impairment. For these patients, we decided to the bypass indication like this. So preoperative management is like this. So single medication is antiplatelets is continued, and avoid dehydration. And we usually perform the about one week's intravenous hydration, and blood glucose controls, and no smokings. And additionally, coronary and cervical evaluation, because to avoid neck impairment, to avoid so positioning to cervical evaluation. So, and we usually use decision making like this, with using the 3D CT angiography and craniotomy. So craniotomy and the tracing of STA and the position of the target M4. And we decide the skin incision like this. Zigzag skin incision, and for the double bypass cases. And intraoperative precautions is like this. So we usually share the information, patient information with anesthesiologist. And during operation, blood pressure is kept and maintained more than 102 millimeters Hg, and ventilator control about normal or normal capnias like this. And positioning is usually jackknife position, and as possible, craniotomy site should be so top level, just above the upper side, to prevent CSF leakage, to avoid brain shrinkage. And about STA harvestings like this, of course, cut down, so for parietal branch, and the frontal branch is like this. So we usually use for about magnification, so enlarge macroscopic. And I will show the videos during the harvesting the STA, cut down, and so to secure the proximal of the STA, and this is a parietal branch, and we usually use a harmonic scalpel. It's very easy and quick harvesting the STA. Here is a frontal branch like this, and freely cutting and like this, about 7 or 8 centimeters we need it both sides. And And after that, occludes the proximal side and cut the parietal branch, and the same way the frontal branch is cut, and we confirm the flow of the blood flow of the both sides. And finally, we usually the internal just a moment. Okay. So wash out the blood using the heparin saline, and using the papaverine to so like this. To coating the cotton with papaverine to enlarge the diameter of the STA. And so dural opening, so before the dural opening, we usually dural surface of the ICG tracing method. Using these methods like this, we can get sufficient and minimally dural opening. We can get necessary and sufficient dural opening like this. And I will show the STA trimming. So to keep the internal, so like this. So we usually call this round method. To Japanese naming is kurukuru method, and it's very easy and quickly trimming of the STA. And direct marking of the and the coloring of the donor and the recipient M4 is like this. And we can get precise and easily operative field, and clean. And as you can see, the right side is the most difficult for the right-handed surgeons. So, if possible, we make the operative field for like this. And the arterectomy is like this. And recipient artery is more than 1 millimeter. Fish-like type is familiar. But on the other hand, thick recipient artery, less than 1 millimeter, straight type incision will be needed. So I will show the video. So direct marking and cuts arteriorectomy using the straight angled dissector, and like this. This recipient is artery is more than 1 millimeter. I will so fish mouth type arteriorectomy will be insufficient sufficient to avoid the opposite side. To avoid the opposite side suturing. And the suture and ligation method is like this. So I will call the railroad method and running sutures. For both methods, we should be avoid the opposite side suturing. So I will show the video. Like this, high magnification, and like this. So railroad method is the safe and easily. And other side, the opposite side, will be like so running sutures. So it's, as you see in the slide, very clear and no bloody operative field. We have to keep the no bloody operative field like this. It's very important. And finally, we have to confirm with ICG video angiographies. So after that, single anastomosis, we can confirm the area of the blood supply, and finally, so we can confirm the to both bypass is successfully. So thank you for your okay. My time is come to end of my presentation. So I would like to emphasize for young neurosurgeons for successful MCA bypass. So the strict surgical indication is very important. And as Dr. Lucia has said, for reduction in periodic complications, we have to train and train and train for anastomosis techniques. Thank you for your thank you for it.
Thank you so much, Professor Otani. So maybe for the time, we can have one comment. So any comment from the from Professor Wada or Professor Shin?
Oh, yes. So I think but we have to proceed this bypass technique. So always.
Any comment from Professor Lucia?
No, it's a good selection of tips to indicate, and for this we must have care in training young neurosurgeons.
Thank you so. So thank you, Professor Otani, for teaching the young this very beautiful illustrated technique for the bypass. I think we all benefit so much from this. So for the sake of time, shall we proceed with our second one-point lesson from Professor Otta about the protective bypass strategy?
Can you see my presentation?
Yes.
Yes. So I would like to start my presentation. My topic of this mini lecture is protective bypass strategy. This is for the treatment for complex intracranial aneurysms. So the concept of protective bypass is to secure distal blood flow.
Sorry, Professor, the screen is not moving. Maybe you have to share it again.
Again? Sorry?
Yeah, it's not moving. The slide is not moving. When you click the button, the screen become paused.
Pause.
It stopped. And the size is not correct. Maybe you can share, unshare, and then when you click the share button, you can share the screen instead of the PowerPoint.
Entire screen.
So just a moment.
Sure. Share. Yeah, maybe you. Yes. Yes. Ah, nice. Yes.
Sorry.
Yes.
Sorry. So the concept of protective bypass is to secure distal blood flow before aneurysm treatment, and it helps reduce the ischemic risk and allows the surgeon to operate with greater composure. This schematic drawing is the right side Fusiform A2 aneurysm by the interhemispheric approach. Of course, at first, both ACA territory is feeding from the bilateral ICA from the anterograde blood flow. And if we treat this aneurysm, sometimes premature rupture or proximal control or trapping is needed to treat this complex region. But during the occlusion, the distal anterior cerebral artery territory may have ischemic risk. So if we do a bypass, this schematic drawing shows left caudal marginal to right pericaudal artery interpositional graft bypass helps the distal blood flow during the temporary occlusion, and we can treat safely these complex lesions. Of course, this needs a meticulous preoperative planning and a blood-brace operative field and an appropriate wide surgical approach. So I will show you first case of this right ACA, distal ACA Fusiform aneurysm with 51-year-old woman. I will show you a video of this case. And Fusiform shaped ruptured aneurysm was observed in the A2 segment. So I decided to harvesting a frontal branch of STA by using purpose of the short graft of the STA by the interhemispherical approach. Because this patient was a young age and ruptured case, I did a large bifrontal craniotomy and interhemispheric approach was performed. And here you can see the white clot was observed. Here will be a rupture point. So I stopped the dissection and I did a protective bypass first. So I did a STA to right side pericaudal anastomosis first. And then I did a left side caudal marginal to STA anastomosis was performed. Another option of this case is A3 side to a side anastomosis. But for the ruptured case and young age is a higher intracranial pressure. So the A3 bypass is a bit difficult and deep for this case. So this bypass is very easier for me. So at this time, the left to side communicating bypass was finished. ICG video angiography shows a good feeling. Then anterior interhemispheric approach was restarted. Fortunately, in this case, I could secure the proximal A2, and ICG shows a good feeling from the bypass. So I can dissect aneurysm safely. At this time, rupture happened, but I can easily control by trapping of this aneurysm. During trapping, of course, bypass can help distal blood flow. So I have enough time to meticulous dissection and confirm surrounding structure. And this was a Fusiform, but I could perform a clipping for this case, but parent artery shows a bit narrowing. So this bypass will great help for this surgery. This is a post-operative CT angiography, shows a complete clipping, disappearing aneurysm, and the patient was discharged with modified Rankin scale 0. And this protective bypass strategy is applicable across most cerebral arterial territories. ICA, ACA, PCA, MCA, and vertebral artery and pica. And we have published previously for each territories. And now, then I will show you case 2. And this is a 46-year-old woman with a pica aneurysm with a thrombosed large aneurysm. Here you can see the thrombosed aneurysm was compressed the medulla oblongata from the backward. So if we simply trapping or temporary occlusion, the slight postoperative increase in mass effect could make central hypoventilation. So we have to do a mass effect reduction by using a thrombectomy of this aneurysm. I will show you the video. And the key to this surgery is to secure the distal pica territory. So after craniotomy, I confirm the aneurysm and distal pica, and Doppler sound was confirmed. And at first, pica was occluded temporarily. And protective bypass for by using occipital artery was performed at first. Now bypass was opened. Again, pica was temporarily occluded, and ICG video angiography shows a good filling of the distal pica flow. So now almost surgery is finished at this time. The carefully thrombus was removed, and by the internal decompression, I could confirm the distal pica here, and aneurysm was trapped. And then thrombus was meticulously removed. And both proximal distal orifice of the pica was confirmed from the inside of the aneurysm. And aneurysm was completely dissected from the circulation. But the part of the aneurysm was severely attached to the lower cranial nerves. I bit remained aneurysm, but I coagulate the vasovasorum like this. After removing aneurysm, I could do enough length of the reconstruction of the pica, so end-to-end anastomosis was performed. During this anastomosis, the protective bypass helped the distal blood flow, so I do not need to think about the occlusion time. And by opening the anterograde blood flow, we should not think about the stump occlusion of the perforator of the pica, proximal pica. Now the ICG shows a good filling of the reconstructed pica. And the patient was had no neurological deficit and discharged with modified ranking scale 0. This is the schematic image and drawing of this surgery. So this is a take-home message. The challenges in complex aneurysm surgery is unpredictable duration of vessel occlusion, and of course premature rupture. It causes an increased ischemic risk, reduced surgical precision. So protective bypass strategy is preemptive preserve distal blood flow, reduce ischemic risk, and allow greater intraoperative composure. And it's applicable to most intracranial regions. In conclusion, protective bypass enables safe and durable treatment for complex aneurysms. Thank you for attention.
Thank you so much, Professor Ota. Indeed, it's inspiring lectures. So,
Yes.
any comment from our discussion, Rasheen or Professor Wada?
Yes. Very interesting, nice presentation. Thank you very much, Professor Ota. So if the OA caliber is very narrow. What do you do? Small caliber OA.
We have
always it's okay.
It's okay.
Almost okay.
We harvest distal OA to proximal, and in many time we have enough caliber from intermuscular layer of the occipital artery. Subcutaneous layer is sometimes very narrow and small.
Narrow, yes.
But go to a proximal and dissection, we can, in many cases, we can have enough caliber of the occipital artery. But if we have no good occipital artery, we need something radial artery graft or a surface vein graft. Yes.
You use graft. Okay,
yes.
Thank you.
Any comment from Professor Wanda?
Thank you very much. Nice presentation, Professor Ota. In case of the giant ACA aneurysm, your presentation and the short graft is a good idea because of the reconstruction of the distal ACA is very, very necessary. You mentioned about to reduce the ischemic complication. And I usually do the STA to the ACA using the radial artery short graft before attack to the thrombosed ACA aneurysm. But in case of your presentation, one side of the Fusiform and also maybe dissecting aneurysm is a good idea for the aneurysm treatment. And you also mentioned about the A3 side-to-side bypass is a good alternative surgery for the treatment. But if the failure, both A3 we lost, so that's a very, very bad situation. So bypass surgery is very familiar for us. So I think your idea is very nice. Thank you very much.
Thank you for your comment.
Okay, so I think it comes to the end of our webinar. Indeed, it's a very inspiring talk on bypass surgery. Shall I invite Professor Kato for your remarks?
Thank you very much. At the beginning, Lucia, my good friend. He's one of the board member of the ISMINS. ISMINS is minimally invasive treatment, but today is quite a maximum invasive treatment, some of the talk. But I think in Europe, I never heard about bypass surgery from my colleagues because Lucia already she mentioned about no moya cases in Europe. And also, I think atherosclerotic change cases is, I don't know if the bypass is useful or not. I'm not sure. So I think maybe the Lucia can be the leader. Just expand of the bypass surgery in Europe, please. And also, Nakatomi Sensei presented a very nice talk. His aneurysm itself is totally different from our usual one because it has kind of the monster he said already. So, but he showed us so many techniques, kind of the CFD or adenosine is cardiac arrest or so many very, very unusual, the technique that he showed us. And also the CPD is kind of the one of the task help for the treatment or make a diagnosis of the treatment. Sometimes I think, but still very fragile. But I think that he mentioned the CFD is one of the good ideas, I think. And also, of course, Professor Otani Sensei, thank you very much for your nice, very basic bypass talk. I think in our department, of course, we have several foreign fellows. They are doing every night is a bypass, of course, the plastic tube. Maybe I think chicken wing is better than a plastic tube, I think. But the very basic bypass technique is very important, I think, in case something happened. Wada Sensei, he mentioned. And also, of course, Oda Sensei is kind of a genius. The surgical technique, I think. Maybe you should more extend your technique to not only the Japan, but also in the world, I think. Sometimes Dr. Ben will visit his place and learn many things from him, I think. I think today's webinar is very worthwhile to listening. Thank you so much.
Yes, thank you so much, Professor Kato. And finally, it comes to the end of the webinar. It's a little bit longer than usual, but it's really, we learn much more from these bypasses webinars. And I'm very honored and hope to learn from all of the master in the future. And on behalf of the Educational Committee of the ACNS and Professor Kato, I would like to thank both the chair, Professor Otani, and also Professor Ota, and also both of our speakers, Professor Lucia and also Professor Nakatomi, for these great lectures and chairing of these great webinars. And also thank you so much, Westin and Professor Wada, for being with us to discuss and then to share about your opinion. Your views are invaluable. And with that, I would like to close today's ACNS ISMINS webinar and hope to see you again in the future. Thank you so much.